organizing committee of the Vietnam Odontostomatology Association, or the BOSA, for inviting me to be one of the speaker for this session. So I have been coming to Vietnam for quite a while, and it is my first time to be invited for the DTEC. And I'm happy that I was given a chance to share a little of my knowledge about MEAW mechanics. So today the presentation is MEAW philosophy, your answer to treating difficult cases. So I have outlined a series of topics, that I will be discussing. I will be discussing about the MEAW and the philosophy. So there are a lot of speakers who are talking about the MEAW mechanics. I would just like to reiterate that what I will be discussing is coming from the point of Dr. Sadao Sato, who is my mentor in the MEAW philosophy. So you might heard other philosophy of the MEAW, other mechanics, but I would just like to discuss more on the perspective of Dr. Sadao Sato. And after that, I will be presenting some of the cases for Class 2, for Class 3, and also for mandibular lateral displacement, as well as for open bite cases. So when we look at the philosophy of the multi-loop edgewise arch wire, when you hear about the lectures of Dr. Sadao Sato, he would always discuss about the cranial bones, because we have to know what causes that particular type of malocclusion. What structure is at fault that resulted to this particular type of malocclusion. So when we try to look at the cranial bone, we have the central bone and we also have the bilateral bone. But I will just talk on the central bone, or what we call the central connection of bone, which consists of the ethmoid bone, the sphenoid bone, the occiput, the vomer, and the maxilla. So when we look at this particular type of bones, there are two movements, that can result to the cranial central bone, or what we call the cranial bone. So when we try to plot the cranial bone, or the angle of the cranial bone, we go from the bastion to sella to nation, and then we will be able to get the cranial angle. So there are two movements that will result to this cranial movement, which is the flexion and the extension movement. So when we look at the flexion, we have a smaller or an acute cranial angle as compared to the extension movement, which gives you a bigger angle. So when we look at the extension type of a movement of the cranial bone, what the cranial bone would do is that it will move the vomer more anteriorly, which is connected to the maxilla, and thereby also moving the maxilla more forward. As compared to if you have a flexion type of a cranial movement, the cranial bone will tip down and it will bring the vomer bone more vertically, and thus it will have more vertical movement of the maxilla, and therefore there's a less antero-posterior growth of the maxilla as compared to the extension type of a cranial movement. So if you try to look at the position of the maxilla, we would want our posterior teeth to be able to erupt by having a good maxillary length. So if you have lack of maxillary length, then what will happen is that you get a lack of space on the posterior area for the teeth to erupt. So when we look back at that particular problem wherein you have lack of space now, okay, for the eruption of the posterior teeth, then we now have what we call a discrepancy. So we have two types of discrepancy. We have the anterior discrepancy and we have the posterior discrepancy. So when we look at the anterior discrepancy, these are a tooth size to jaw base discrepancy, wherein we base it on all the teeth that are anterior to your posterior teeth or your first molar. So any discrepancy, any lack of space, okay, for the eruption or for the alignment of your anterior teeth, meaning from premolar all the way to the incisor area, then we consider that as an anterior discrepancy. And for a posterior discrepancy, it is also a discrepancy wherein there's a lack of space, okay, or tooth size to jaw base space, wherein we consider it from the first molar backward, meaning we are taking into consideration the first and the second and the third molars. So these are areas wherein we have lack of space for the eruption of the second and the third molars. So when we have a posterior discrepancy, then what will happen? When we have lack of space on the posterior teeth, and when the second molar started to come out, or when the third molar started to come out, because of the lack of space for the eruption of the second and the third molars, it will cause a squeezing out effect on the first molar area. So what do I mean by squeezing out effect? Meaning, the second molar in the time of eruption will push the first molar downward because it wanted to erupt. So when it causes the first molar to push down, then the first molar will cause an interference on your mandibular teeth. And because of the interference on that particular area, then it resulted now to different types of malocclusion. So, when we try to look at the concept of posterior discrepancy, we have to think that any type of discrepancy, any type of lack of space on the posterior area from first molar backward, okay, it causes now a problem which resulted to either a forward or a backward movement of the mandible. So when we look at the posterior discrepancy, as what I mentioned, there will be a squeezing out effect on the posterior teeth area because of the eruption of either the first, the second, or the third molars. Then it causes an interference, okay, or a fulcrum on the posterior region. So when you have now a fulcrum on the posterior region, then what will happen? You will be able to change now your occlusal plane. So meaning your occlusal plane now will alter or will change either from a flat to a steep or to a flatter type of an occlusal plane. So when you have a different types of occlusal plane, then it also have an effect on where your mandible will go. So either your mandible will go in a forward rotation or it will go in a backward rotation. So when we now look at the occlusal plane change, it is always almost synonymous with rotation of the mandible. So Dr. Sadao Sato made a lot of research with regards to the development of the malocclusion from childhood to adulthood, and he tried to track, okay, if this particular type of malocclusion is also affected by the type of occlusal plane. So it means that when your occlusal plane started to flatten, okay, meaning it started to go down, then it also brought your mandible to go down and forward, which resulted to either, okay, a class 3 type of a malocclusion or an open bite type of a malocclusion. And if your occlusal plane maintains in a steep occlusal plane, then your mandible is always in a retrusive type of position. So if you try now to look at the growth direction of the maxilla, we all know that the maxilla grow in a forward and downward direction. Okay, that is usually the normal growth pattern for the maxilla. But as what I said, okay, with regards to the cranial bone, okay, especially the central bone, it has an effect on where your maxilla will go and how your maxilla will grow. So when you have an extension type of a movement or of a cranial movement, then because of the movement of the cranial bone going upward, okay, it pushes now your vomer to go more forward. And when your vomer goes more forward, it also brought your maxilla to go forward. And you can always see this, okay, in a class 2 type of a malocclusion. While if you have a flexion type of cranial movement, wherein your cranial bone now picked downward, okay, it also brought your vomer to go downward. And because of that, you get lack of anteroposterior growth of the maxilla, but instead you have more of a vertical growth of the maxilla. And what will happen? You get lack of growth, lack of anterior movement of the maxilla, and then now your mandible is growing more than the maxilla. Then you get now the class 3 type of a malocclusion, or maybe an open bite type of a malocclusion. So when we look, okay, at now the type of the cranial base, we would now relate it to the different types of malocclusion based on how the cranial bone moves and how it will bring your maxilla either forward or downward. So for the class 3 type of a skeletal pattern, we would always see a flexion type of a cranial base, meaning there is a lack of growth, okay, anteroposteriorly of your maxillary length, okay, which resulted now to a posterior discrepancy because there's lack of space now on the posterior area of your maxilla. Then there will be squeezing out effect of your posterior teeth, and there will be a fulcrum which causes the mandible now to go more forward. As compared to it, you have a very good, okay, growth of the maxilla, okay, then you get the class 2 type of a skeletal structure. So we would always relate that, okay, to either a flexion or an extension type of a cranial base movement for us to be able to come up with what kind of skeletal structure that particular patient will have in the long run. So when we now try to go into a class 2, okay, type of a malocclusion, okay, when we look at the treatment mechanics for class 2 malocclusion, we have now a molar that are in class 2 relationship. The canine are also in class 2. We have a very big overjet. It can either be a deep bite case or it can be an open bite case. So it depends on what type of class 2 the patient has. Then our usual treatment objective will be to make the molar into class 1 and the canine to be in class 1. So it's either you have a very prominent maxilla, meaning overgrowth of the maxilla, and a normal mandible. Then if that happens, then what we want to do is we wanted to push the maxilla a little bit backward so that you get a normal facial appearance. So some of us would probably use a headgear to be able to push the maxilla backward. And especially if the patient is still growing, then we can do that by growth modification to change the growth pattern of the patient and make it into a skeletal class 1. Other option that we might probably do for a class 2 type cases is that we do extraction of the first premolar. So when we do extraction of the first premolar, especially in adult patients wherein we do camouflage type of a treatment, okay, then we would want to retract out the canine and do the anterior retraction to be able to reduce and improve the overjet of the patient. So this can only happen if, okay, the mandible is normal, the maxilla is probably in an abnormal position, that you would want to do a camouflage type of treatment to extract and move the anterior teeth backward just to be able to improve the facial appearance of the patient and also improve, okay, the protrusion of the anterior teeth. So, but if you have mandible that are retrusive, okay, in a class 2 cases wherein the maxilla are in a normal position, but the mandible are in retruded position, then doing extraction of the upper first premolar might not be a good choice of treatment because the at-fault jaw is the lower and not the upper. And if your treatment is directed to the upper teeth, then you are not improving the profile of the patient, but at the same time, you are just worsening the case because you did not correct the position of the mandible. You maintain the position of the mandible and then you just do anterior retraction. So, for that particular case wherein you have a retruded mandible, your treatment options might probably be to rotate the mandible to go forward rather than to do extraction of the anterior teeth to retract the upper teeth. Okay? So there are a lot of treatment mechanics, okay, that you can do, okay, in terms of how you correct the class 2 relationship. Okay? So I'm just giving you one of the options, okay, that you can use, okay, in your clinical practice. Okay? So here is a very young patient, okay, he is like 10 and a half years old, okay, boy. Okay. If you try to look at the lip position, okay, he has a little bit of a lip incompetence, okay. Upper midline is on, okay, there's a series of diastema because the patient is still in what we call the agriducting stage, wherein some of the teeth are still in the decidus dentition stage. So he is still in the mixed dentition stage, okay. And the profile, you can see that in the set, okay, the mandible is a little bit more retruded, okay, as compared to the maxilla. Intraorally, okay, you can see now, okay, the right side canine is starting to erupt, but the left side is still inside the bone, okay. You have a very big overjet of 13 millimeters, and you have a big bite of almost 50% for the central and 100% on the lateral incisor area. So you can see now the lateral incisors are more extruded, okay, than the central incisor. Lower midline is slightly shifted to the right side, okay, but it is not, okay, that significant, okay, because our main concern now is to improve, okay, the facial profile of the patient. So molars, okay, are in class 2, canine and also in class 2 relationship, okay. Occlusally, okay, you can see already the unerupted canine on the lower, okay, all the teeth have erupted except for the second molars. When you look at the cephalometric radiograph, okay, we do the denture frame analysis, okay, if we are using the MEAW mechanics, okay. So you can see that the mandibular plane angle is normal, okay. The occlusal plane is almost normal within the range, but at the lower end, okay, it shows you that the occlusal plane is a little bit going to a steep type of an occlusal plane. If you look at the anteroposterior, AP, okay, which is the length of the maxilla, okay, you get a very big length of the maxilla, okay, because he is a class 2 type of a skeletal pattern. Okay. And if you look at the intermolar, okay, you get a little bit of a protruded or a protrusive type or mesially inclined molars, okay, on the area, okay. And if you look at the ODI, or what we call the overbite depth indicator, we have 83 degrees. It's telling us that the patient has a tip bite tendency, okay. And we get 57 for the APDI, or what we call the anteroposterior dysplasia indicator. Then it tells you that a smaller value, then you get a skeletal class 2 pattern. So this particular patient, okay, is a class 2 skeletal tip bite type of an occlusion. Panoramic shows you all the posterior teeth are present, including the third molars. Okay, although they are the lower, okay, will be impacted, okay, but the upper is still very high up. Okay, so for this particular patient, okay, we try to do non-extraction therapy and try to stimulate, okay, the growth of the mandible to go a little bit more forward to improve the facial appearance of the patient. So there are a lot of mechanics, appliances that can help you, okay, in rotating rotating the mandible in improving the facial appearance of the patient. But for this particular patient, we decided that we try the multi-loop edgewise arch wire, okay, with a class 2 mechanics, okay, which is the class 2 activation to be able to improve and try to move the mandible forward. So, the patient did not have all the third molars extracted because the parent doesn't agree to have an early extraction of the third molars. So we delayed the extraction of the third molars and just proceeded with orthodontic treatment. Okay. So we do the leveling and alignment stage. Okay, you can either proceed with either a night-eye wire, a thermal night-eye wire. It's your choice of materials, okay, or a stainless steel or a multi-stranded wire. Okay. So we just do the strap up of some of the teeth, okay, except for the canine because they are still not yet erupted, okay, not fully erupted. So what we do is we do the level alignment, try to level the lateral and the central incisor to improve the position with the central incisor. So once we leveled all the arch, okay, then we started to close some of the diastema that are present on the anterior region, okay. And then, okay, when the canine is enough for us to bond, okay, then we use the loop mechanics, okay, to be able to align and upright the canine. So you can also do the night-eye wire with this. You don't need the loop, okay, to be able to align the canine. Okay. It just so happened that this particular case, we did it a little bit early, okay, and we do all the loops, okay, mechanics to be able to align and level the arch. So after all the canines were aligned, okay, then what we did is we install now the multi-loop edgewise arch wire, okay, and then we do this class 2 type of an activation, okay, wherein we have all the step-down bends, okay, the progressive step-down bends on the distal of the canine all the way to the molar, okay, because we wanted to make the occlusal plane a little bit flat, okay, so that we will be able to move the mandible forward or rotate the mandible forward and reduce the overjet of the patient. So by also increasing the vertical dimension, okay, we can also improve, okay, the dip bite tendency of that particular patient. So there's a progressive tip back bend, okay, and at the same time a progressive step down bend, okay, on the molar, premolars and molars, okay. And for the lower, we did the tip back bend, okay. We did not do extrusion bend, okay, because we still wanted to level, okay, the arch of the patient and flatten it, okay. So we did a progressive tip back bend. And we asked the patient to wear a short class 2 elastics, which is a 3/16 6 ounces elastic. Okay? So you can either use the upper first loop to the lower second loop or upper first to lower third loop. Okay? So that's how we would ask the patient to use, okay, the elastic. So eventually, okay, you gradually just appoint the patient, and maybe if you need to increase more your step down bend, okay, then this is the time that you can crimp, okay, the loop, okay, to make the step bend, okay, more vertically down. So this is the occlusal view. And once we were able to achieve now the class 1 molar, okay, then we have some spaces now for us to be able to do a little bit of an anterior retraction, okay. So we change now the wire to an ideal rectangular wire, SS. Okay? So during this time, I'm still using the 18 slot brackets. Okay? So my final wire is a 17 by 25. Okay? But eventually, I changed now to 22 slot. Okay? This was before. Okay? I am practicing 18 slot. Okay? But now I do the 22 slot. Okay? So because the lower, we don't have any more the loops. Okay? Then I use the Kobayashi hook, okay, and ask the patient to wear very short class 2, okay, elastics, okay, just to be able to maintain, prevent the mandible from going backward, okay. and trying to suck in, okay, or improve the interdigitation on your premolar molar area. And after that, we remove now the braces, okay. So we're able to improve now the positioning of the mandible, okay. And this is the bite of the patient, okay. You get a good interdigitation on the premolar molar area, okay. Unfortunately, we cannot anymore move back more or move forward more the mandible because you might destroy now the occlusion on the premolar area, okay. So we get now a good overjet overbite, okay. And this is the occlusal view, okay. And if you try to look at the profile of the patient, okay, you were able to move the mandible forward and improve, okay, the profile of the patient, okay. We were also able to improve also the nasolabial angle, okay, instead of from a very protruded lips, okay, we were able to move it a little bit backward, okay, because of the spaces that we were able to create, okay, distal to the lateral incisor for us to do anterior retraction. So, I was not able to meet the patient for quite a while, okay, and then suddenly, okay, I saw the patient again, okay, during one of the weddings, okay. So, unfortunately, I was not able to approach the patient, okay, he was already an adult, so I tried to check on his Facebook, okay, because Facebook is where we look for our lost friends, okay, or our lost patients, okay. So I tried to look at the Facebook, and I was able to find him, okay. And I grabbed the photo, okay, and this is 16 years after, okay. His profile is still okay, okay. The mandible is still in the good position, okay. He's not wearing any more appliances or fixed retainers, okay. This is the photo that he is going to get married already, okay. So, but I don't have the intraoral photo, I just have the picture of him, okay, because I just grabbed it from the Facebook. So if you try to look at another case, this is from Dr. Sato, okay. This is also a very young patient, okay. Also in the mixed dentition stage, okay. If you try to look at the lip area, okay, he also has a lip incompetence, okay. Mandible is a little bit protruded, okay. Maxilla is a little bit more forward in position, okay. Intraorally, okay, you can see a full 100% dip bite, okay. A big overjet of around 15 millimeters, okay. You get a full class 2 canine relationship, okay. Molars are also in class 2, okay. There's still, okay, the decidus dentition, okay, on the second decidus molars, okay, or what you call the E, okay. So it's still not yet erupted. So for this part, if you look at the cast, okay, you can see now the position of the molar, okay. It's a full cast second molar, class 2 first molar, okay, and you get a canine that are full class 2 and a very big overjet. Cephalometric, okay, you can see a retruded mandible, okay, which is 75, okay, and then the ODI, okay, is 85, which is very deep bite, okay. ODI is, if we refer it either to an open bite or a deep bite. So a very deep 85 is considered to be a deep bite case, okay. And APDI of 68, okay, normally it's 81, okay, so it's a skeletal class 2 facial appearance. So we can probably say this is a skeletal class 2 with a retruded mandible. Panoramic, you have all the teeth present, including the third molars. Okay. So in cases of class 2, okay, skeletal pattern, okay, we are not that concerned about the third molars. Okay. But if it is a class 3, we would, as much as possible, have the third molars removed. Okay. But for class 2 cases, sometimes we can delay the extraction or the removal of the impacted third molars. So what Dr. Sato did is he wanted to open up the bite, okay, by using what we call the double arch wire. Okay? So he used two wires, okay, a rectangular wire on the 4 incisors and a square wire on the accessory wire. Okay? So the main purpose of this double arch wire is we would want to intrude, okay, the anterior segment or the anterior teeth. Okay? So this was during the time where implants are not yet available. Okay? So we have to make use of the different mechanics, okay, available for us, okay, to improve or to correct the deep bite or the open bite. Okay. But nowadays, okay, we are lucky, okay, that we have lot of accessory orthodontic materials, especially the implant, that will help us, okay, in our treatment mechanics. So from a 100% deep bite, okay, you can see now that the bite opens, okay. You can already see the lower teeth. Okay? And if you look at the posterior area, okay, the E is still present. That's why we have to bypass it. Okay? They just included the second premolar, the first premolar, and solder the wire. Okay, so this is a square wire, okay, and solder it, and then a rectangular wire. Okay, so the bend, if you try to see, passively bended. Okay, just to be able to get whatever position the incisor are, okay, because we are not yet in the leveling. What the purpose of the double arch wire is to open the bite, to improve or correct the deep bite. Okay, so that's our main goal, okay, for this particular situation. So you get an activation, the wire, there's a helix, okay, the wire goes up, and then you bring it down and hook it onto the sectional wire. Okay. So when we do this particular type of movement, okay, we don't have the absolute type of an intrusion, okay, because there will always be a side effect, okay. When we do this particular mechanics, yes, our anterior teeth will intrude, but what will happen also on our posterior teeth? Posterior teeth will extrude, okay. That is a side effect. But good for this particular patient because it can help us in opening up the bite and improving or correcting the deep bite. Because if the patient is open bite and you do this particular mechanic, then it worsens. It will make the open bite more. But for this particular case, it's a deep bite case. Opening the bite, extruding the posterior teeth, okay, it helps you correct the deep bite tendency of the patient. So this is after a few more months. Okay, you can see now that the incisors are more upward. You just leave the canine. Canine now becomes a little bit, looks a little bit longer because you are trying to intrude, okay, the 4 incisors. Okay. And once all the teeth are erupted, okay, all the permanent teeth have erupted, okay, then you can already do the leveling and alignment, okay, during this time, okay. You do level align, okay, to be able to make the canine in level with the incisor, okay. Of course, if you do level alignment, you can see that the bite started to close again, okay, it started to deepen. But it is not as deep now as compared to the original position, okay. So, after you do the leveling and alignment, okay, if you try to compare, okay, the before, okay, and the after, okay, the canine, if you look at the position of the canine, okay, the mandible moved a little bit forward, okay, because you extruded the posterior segment, you try to somehow rotate the mandible forward. That's why the overjet reduces, okay, as you use the double arch wire. Okay? So you look at the canine position, okay, it improves, it now becomes cast to cast from a full canine class 2. So when you have already this particular type of a condition, okay, now you can change to the multi-loop edgewise arch wire or the MEAW wire, okay, and then you can do now the class 2 mechanics, okay, to further move the mandible forward. Okay. So when we use the multi-loop edgewise arch wire, you automatically have to ask the patient now to wear, okay, the class 2 elastics. Okay, it cannot be that you use the MEAW wire and the patient doesn't wear the elastics. Then it will not work. It will just worsen the bite. Okay, so you have to make sure that the patient is continuously, okay, using the elastics. Okay, when you are using the multi-loop XY wire. So from this particular bite, okay, then you can now do a step down bend, okay, which is like what I did in a previous case. Okay, you do a progressive step down bend, but this particular case, because we further would want to open up the bite, okay, that's why the lower arch we also did the step up bend. Okay, so you have to step up bend to further make, okay, an interference on the posterior area. Okay, because if you do step up, okay, there will be an interference on the posterior area, and with the help of the elastics, the mandible will rotate forward and become class 1. So you will be able to see now canine almost starting to become class 1. Okay. So on the other side, on the left side, you have more canine class 1 now as compared to the right side. So you continuously move, okay, this particular arch, okay, continuously ask the patient to wear the short class 2 elastic until you'll be able to achieve a class 1 canine molar relationship and a reduced overjet. Okay. So as the mandible goes forward, you can also see an improvement in your dip bite because you are moving the mandible forward. It also increases, okay, the anterior vertical height on that area. So once you get now into a class 1, okay, so Dr. Sato added, okay, another wire, okay, which we call the mulligan wire, okay, it's an overlay wire, okay. This is used to expand a little the posterior area to improve the buccal overjet, okay. So you can expand using the wire by itself, or you can use this particular mechanics to help you, okay, expand the arch. Okay, so it's up to you if you want to use this or you just want the arch wire expansion. Okay, so they use the mulligan wire, okay, to expand the posterior area. Okay, and once you get now into good buccal overjet, especially on this area, okay, then you can remove now the overlay wire. Okay. And then now, canines and molars are now both in class 1. Then you can already change now your wire, okay, to your ideal wire, okay. So when you are now changing to an ideal wire, you still have to use elastics, okay, to prevent the mandible from relapse to go backward. Okay, you wanted the mandible to still maintain that particular position. So once everything is now in good position, okay, then you can now remove, okay, your braces, and then you get now a full class 1 canine molar relationship and a good overjet and overbite. So this is the occlusal view. Okay, and if you look at the profile of the patient, okay, you improve the profile of the patient. Okay. So from a very acute nasolabial angle, okay, you were able to also improve, okay, the nasolabial angles. So this is during laterotrusive movement, okay, you wanted to check on your laterotrusive movement, okay, so the patient has a canine, okay, guided occlusion, okay, when you ask the patient to move either to the right or to the left side, okay, only the canine are in contact, okay, while the rest of the posterior tissue are free, okay, then you will be able to say that, yes, I was able to make a good occlusion, okay, even during movement or laterotrusive movement. Okay. So this is the panoramic, okay, the third molar, lower third molars were removed, but the upper is still there. So this is 2 years post-treatment, okay, you still see you were able to still maintain, okay, the occlusion of the patient, the profile of the patient is still good. Okay. So this is the cephalometric radiograph of the patient. Okay. and the superimposition from the before, okay, and the after. And this is 4 years, okay, post-treatment. Okay. So, profile of the patient still looks good. Okay. And if you look at the occlusion of the patient still has the class 1 canine molar relationship and foot overjet over time. And this is the occlusal view of the patient. So if you try to compare now the progress of the profile of the patient, okay, from a little bit of a retruded mandible, okay, wherein you move, okay, the mandible a little bit forward, okay, you improve now the appearance of the patient as the patient grows older. So, another patient here, okay, this is already an adult patient, okay, patient profile, okay, looks good, okay, he has a midline that is symmetrical with the facial midline, okay, fairly competent lips, okay, a little bit of a hyperactive mentalis muscle, okay, during closure. The patient's vertical dimension on the lower third of the face is a little bit short, okay, as compared to the normal height. Intraorally, okay, you can see now a full dip type, okay, a full class 2, okay, canine relationship and molar, okay, on both sides. This is the occlusal view. Okay, all the second molars were also erupted. Okay, so if you look at the arch form of the patient, the upper arch is not symmetrical with the lower arch. Okay, the upper is more of a square type of an arch shape, while the lower is more of an ovoid type arch shape. So clinical findings is for this particular patient, the patient has pain, okay, on the right posterior area of the joint, okay. He has a reciprocal click on the right side, okay. And when we ask the patient to move the jaw a little bit forward, okay, and then try to open and close, okay, the joint sound reduces, okay. So the patient also has a dip bite, okay, a class 2 canine and molar relationship, okay, and a deep mentolabial fold. Cephalometric, okay, pre-cephalometric, you can see now a skeletal class 2, okay, because of the APDI, which is 77 degrees, okay, and you have a very flat anterior occlusal plane and a steep posterior occlusal plane. So the patient has like a dual occlusal plane, okay, dip bite tendency because of the ODI, which is 76. So panoramic, okay, all the third molars are absent, okay. The patient only has until second molars, okay. So the treatment plan is to use the double arch wire, okay. After double arch wire, do the leveling and alignment, okay, and then do the multi-loop edgewise arch wire, and then now you go into finishing and retention. So, for the double arch wire, okay, this is after 2 months of wearing the double arch wire. Okay, so you just, even if there's already the presence of the permanent teeth on the canine and premolar, okay, you just bypass it, okay, because we wanted to just intrude the 4 incisors and use the first molar as your anchor. So, we did not do the soldering type, okay, just the helix, okay. So this is a square 16 by 16 and a rectangular 16 by 22 SS wire for the sectional one. Okay, so do a tip back bend on the distal part of the helix. Okay, so when you insert it onto the molar tube area, this wire goes up and then you bring it down to hook it onto your sectional wire. Okay, so with this particular mechanics, okay, you can intrude your incisor and extrude your molar and improve the vertical dimension of the patient. So 4 months of with the use of the double arch wire, okay, you can see already an improvement in the anterior segment, okay, from a 100% bite, now you can see 50% of the lower incisor. So from there, okay, once you were able to achieve now, okay, the normal overbite, okay, then you now change to your multi-loop edgewise arch wire, okay, you install it, okay. So for this particular case, the canine was bypassed, okay, because if we include now the canine, the incisors, okay, might go back, might extrude, okay, and we want to maintain, okay, the correct overbite, and we want during this time to still further open the bite and move the mandible more forward. So we just bypass the canine, okay, and do a progressive step down bend, okay, on the molar, premolar area, okay, and use the short class 2 elastic all the way until the third loop of the lower. So this is still using the class 2. You can see now the bite, okay, started to go forward. The mandible started to move forward. Okay. Canine now is in the cusp-to-cusp relationship now. Okay. So you just continue with the step down bend on the posterior area and also on the lower because you wanted to increase more the bite. So you still continue, and then we just use the triangle, short class 2 triangle vector elastics, okay, to further move the mandible more forward. Okay. So until such a time that the mandible is almost in the edge-to-edge bite, then we can already place bracket on your canine, okay, and do the releveling with the use of the MEAW wire. Okay. Then if there's any further extrusion of the anterior teeth, okay, it will go into normal overbite. So now canine, place the bracket of the canine, okay, and still continue with the class 2 elastics. Okay. This is on the third month, okay, of the use of the MEAW wire. Okay. So the bite now is almost going to class 1. Okay. So we don't want to further move the mandible forward because it will now become class 3. Okay? So we just change the vector of the elastics to a vertical elastics, which is from upper first to lower first loop. This is on the 6th month, okay, of the MEAW wire. So just improving the interdigitation. And use a little bit of a class 2 again, okay, to improve further, okay, the bite of the patient. Until you get now into a good interdigitation on the premolar molar area, okay, then you can already remove now the braces. So if you try to look at this is the occlusal view. So this is now the face of the patient. Okay. You still maintain a good straight profile. Okay. You increase the vertical dimension of the patient. Okay. This is the set. Okay. We're able to flatten now the occlusal plane. Okay. This is the panoramic. So if you try to compare now the before and the after. Okay. So his face totally changed, okay, just by increasing the vertical dimension of the patient, okay, improving it, okay, it changes the facial appearance of the patient, okay, and without doing any extraction, okay, just by moving the mandible and rotating it forward, okay, you will be able to get into class 1 canine and molar relationship. So if you have another patient, okay. So this is another patient, okay. It is a transfer patient, okay. So the patient parents are both dentists, okay. So they were under the care of another dentist for many years, okay, I think more than 5 years already with the orthodontic treatment. So, and then they decided, that particular dentist decided to transfer, okay, because of the problem that that particular dentist felt that she cannot correct it. That's why she transferred it to our dental clinic. So this is the pre-treatment picture from the previous dentist. Okay? So the patient is still very young when he underwent orthodontic treatment. So you can see a typical type of mixed dentition stage profile. Intraorally, okay, only the 4 incisors and molar, permanent first molars are present. The rest are still in the deciduous dentition stage. Okay. So, this is the occlusal view, okay, of the patient, and the cephalometric radiograph showing a little bit of a protruded incisors, okay, and a class 2 molar relationship. And panoramic shows you the unerupted canine and premolars on the upper and the lower. So if you try to look here, this is before the dentist did the orthodontic treatment. Okay. So it looks fairly normal, okay, in the panoramic, okay, except that the canine position. Okay. If you look at the canine and the first premolar, okay, it almost gives us a little bit of a warning, okay, as to where that particular canine will go in the future. Okay. But we are still hoping that the canine will go into the position, okay, where the canine should be. Okay. So the patient did orthodontic treatment. Okay. And this is from the previous dentist. Okay, they did the strap up, okay, of the teeth, and they try to do the level alignment. Okay. So when they are waiting, okay, when the previous dentists were just waiting for one canine to erupt because the other canine already erupted. So they decided to take a panoramic radiograph. So in that panoramic radiograph, okay, they saw, okay, that the canine is in between the first and the second premolars. Okay, so it's a transposed type of a canine position. So this is the periapical radiograph of the patient. So because of this condition, okay, they referred the case to our dental clinic, okay, to have the canine in the correct position. So because both parents are dentists, okay, they wanted that the teeth of their child will have a normal positioning of the teeth. Okay, meaning canine should be on the position of the canine. It cannot be transposed, okay? Because if I had the chance, I will just extract, okay, if you try to look at the panoramic, I will extract the deciduous canine, I will move the first premolar forward and then just extrude the impacted canine, then that is the ECS, okay? You don't need to transpose it. But unfortunately, the parent, okay, who are both dentists, okay, disagree with that particular type of treatment. And they prefer that we transpose, meaning move the canine into the correct position. So we tried to discuss all the scenarios of doing that, okay, because the premolar is a birooted tooth. So you have, the patient has a very thin gingival biotype. So the canine is not palatal, it is on the labial position. So if we pass through the first premolar, there's a chance that the premolar root, especially the buccal root, might get resorbed on the process of you moving the canine over the first premolar. And another one is there will be a lot of gingival recession, okay, on that particular area. Taking that into consideration, the parent is still insisted, okay, to have the transposed tooth in the correct position. So we did a lot of discussion, signing of waiver, or just to be able to make sure that at the end, okay, they will not blame us, okay, for whatever things that will happen to their child. So after, when the patient came, okay, the patient is wearing a single wing bracket, okay. So I decided not to change anymore the bracket, okay. Even if I don't use this bracket because I use a twin bracket, I don't use a single wing bracket. But it doesn't matter, okay, as long as you make use of the bracket positioning, okay, and you don't need that much of movement, then we can still perform the mechanics that is needed. So we open up a window type, okay, because the canine is already there. When we open it, okay, there's no bone to reduce, okay, so meaning that the canine is just on the labial surface, okay? And we solder the wire, okay, with a helix, okay, because we wanted to move the canine out, okay, buccally, okay. So closer view, okay, you can see now the wire is positioned buccally, and then we try to push it, go into the button and tie it. So that the action will be going to the buccal position. Okay. So when the canine is already almost out, okay, we place now the brackets of the premolar, and we try to do an inset dent on the premolar because we wanted to move the root and the crown of the canine, premolar lingually. Okay. So if you look at the occlusal view, okay, you have now the step-in dent or the inset dent, okay, while we are moving the canine buccally. So this is the periapical view, okay, just to be able to see, okay, of the movement of the canine. So canine now is on top of the premolar, okay. So we started to now open the space, okay. So I'm just showing you what I did wrong, okay. I made a mistake for this particular case, because this is the case that I treated when I just finished my schooling, okay. I just graduated, and I'm just in my early practice, okay. We sometimes would make some mistakes along the way, and from there we learn from our mistakes. No? So I just wanted to share to all of you, okay, the mistakes so that you don't do it, okay, during when you have this particular case. So for this case, okay, I have two wires, okay. One is a night-eye wire, a round night-eye wire, because I wanted to try to bring the canine down, okay, and at the same time, I wanted to also bring the canine initially with the use of the power chain. And my base wire is a 16 SS wire, and I use a coil spring, okay, to open the space because I felt that this particular space is not enough for my canine to accommodate my canine. On the left side, I don't have any problem because I already was able to get into a class 1 canine molar relationship. My problem is now on the right side. So when I was doing, okay, this particular mechanics, if you try to look at this particular area, I placed a lingual root point on my premolar because I wanted the root to go lingually so that there will be enough space for my canine to pass through the root. Okay? That's why you can see now, okay, the position of the crown, okay, the lingual cusp of the first premolar is now extruded, okay, and is now in contact with the lower premolar. Okay? So that is my thinking that this wire, okay, will bring my canine down, and my power chain will slide my canine initially. That is my intention. That is my goal, okay, when I was doing this particular mechanics. But when the patient came back after 1 month, okay, I was shocked, okay, with what happened. Okay. There is now a canting of the occlusal plane. My anterior segment, especially on the canine area, had an open bite. Okay, so there is now a canting, okay, of my wire. Okay, why does it happen? Because I made a mistake in my wire of choice. Okay, instead of preventing the canting, okay, I created the canting wire because my base wire is a round wire. It is not strong enough, okay, when I was pulling my canine initially and bringing it down. The canine is too strong, the root is too long, okay, that the incisors went up same level as the canine. Okay? So, if I was to do it all over again, okay, my base wire, I will just use a rectangular SS wire, and my accessory wire will still be the night-tie wire. Then I will be able to secure, okay, my wire, and I have to figure eight tie them as one segment. Okay, that it prevents it from happening. So when the patient came, okay, even if I was so scared, okay, I did not show it to the patient, okay, because the mom is always there looking. She is always beside the dental chair, looking at how I will do. Okay, so that's the stress of any orthodontist when the parent, okay, of the child who is a dentist is sitting on beside you and looking at every step that you are doing. Okay, so of course the mom asked, "What happened? It became open bite." Then I just said, "It is a process. Okay, you just have to wait. Okay, and then we will bring it down. Okay, but of course with lots of prayers. Okay." I change again to night-tie wire and try to re-level it again. Okay? So, it was, I mentioned that there is a recession of the gingiva, and it happened. Okay? There is a marked recession of the gingiva on the canine area because of a very thin gingival biotype for this particular patient. Okay? So, but the parent accepted it. Okay? So, during this time, I removed the bracket of my first premolar because at first it is a single wing. I changed it now to a twin bracket, which is a two-wing, okay, because I felt that I can work on the twin bracket efficiently than a single wing. Okay, that is just me. Okay, maybe if you are used to the single wing, then there's no problem with it. Okay? But I'm just not comfortable with a single wing. That's why I have to change it to a twin bracket because I felt that I need now, okay, to torque again, okay, this particular tooth, okay, meaning I need to make the root go buccal so that the cusp of the premolar goes up and it will close now the bite. Okay? So first night-tie wire and then change it to stainless steel wire and do the torquing. So this is the occlusal view. So patient came back, okay. I'm already now in my stainless steel wire, rectangular wire, okay. And then I just place loop mechanics, okay, just to close some spaces. But here, you see the recession of the canine area. But now the canine are almost in class 1, good overjet overbite. So we are still trying to improve it, okay? And then we remove now the braces of the patient, okay? Because the patient already have also to go out of country, so they are not based in the Philippines anymore. They are in another country now, staying in another country. Okay? So this is the final result. I could have poured more the root more lingually if I have the chance now, okay? Then I can probably reduce a little of the recession of the gingiva. But during that time, I did not do it, okay? So if I were to do it again, okay, I will probably do the torque on the canine more, okay, just to improve the position of the canine. So this is the occlusal view. Okay. So if we go now to a class 3 type of a malocclusion, okay, so when we look at the class 3 malocclusion, okay, we can